Hi, Marty.
Hi, Stephanie.
I think we'll probably start the session now. Just wanted to welcome everyone. It's right on 12 noon for our session on the neuroblastoma conference on what is a clinical trial and what parents should consider. My name's Stephanie Dunstan. I'm the moderator for this session, and I'm very interested in the session. I've sadly lost my daughter Saskia to neuroblastoma, so I'm keen to support the conference. Just a quick introduction to Dr. Martin Campbell. Probably people online may already know him, but he's the clinical oncologist at the Royal Children's Hospital in Melbourne. He's the clinical lead in solid tumours, so I'm sure he's got a very strong interest in clinical trials, which is a really complex area for parents to understand and navigate if they're considering those options. And I'm sure we're going to have lots of questions for Marty. So how we'll run through this is that Marty will present for about 30 minutes, but as you're listening to Marty's presentation, do feel free to write a question in the box. And you can also look at other people's questions that are there. And if someone's thought of a question that you wanted to ask, just you can prioritize that question so we get to those at the end. So Marty will present for about 30 minutes and we'll have about 15 minutes for Q&A. And yeah, I'll hand over now to Marty to make his presentation till about 12:30.
And thanks very much, Stephanie. Thanks for asking me to come speak today. I will just share my screen. Can everybody see that now? I should ask Stephanie. I assume you can see that now. So yes, the title of my talk is about clinical trials and what parents should consider. And yes, I'm a paediatric oncologist at the Royal Children's Hospital in Melbourne. I head up the solid tumour program here and actually the acting chair of the anti-toxic solid tumour group at the moment. And actually did a master's in clinical trials. So it is something I'm very interested in and is really a cornerstone of paediatric oncology and how we like to improve outcomes for kids with cancer. So I'll just start with a brief rundown for this session. I'll first just quickly define what a clinical trial is, hopefully answer the question of why do we perform clinical trials. There are obviously various different types of clinical trials, and within the treatment trial group that I'll be mainly talking about, there'll be different phases of clinical trials to discuss. There's other trials that I'm just going to briefly mention. I'll talk about the levels of evidence very quickly with regard to the results from clinical trials, and finishing off with what else do you need to consider. And I'm very much hoping there'll be a lot of questions generated from this, which hopefully I'll be able to answer some of them for you. So just as a definition, this is from the WHO as to what a clinical trial is, and it's basically any research study that prospectively, which means it assigns human participants or groups of humans to one or more health-related interventions to evaluate effects on health outcomes. So in neuroblastoma clinical trials, it's mainly about new drug treatments. So clinical trials are research investigations in which people volunteer to test new treatments, interventional tests as a means to prevent, detect, treat or manage various diseases or medical conditions. Now, clinical trials importantly are voluntary and are governed by very strict rules and ethics. And there's a lot of background that goes into making sure clinical trials now run appropriately. So why do we perform clinical trials? Look, because they're essential to the development of any new medical treatment or diagnostic tests. Without clinical trials, we cannot properly determine whether new treatments developed in the lab or by using animal models are effective or safe, or whether a new diagnostic test may work properly. And this is because computer simulation and animal testing can only tell us so much about how a new treatment might work, and there's no substitute for testing the living human body. And in children, is a new area of complexity because children are different to adults. Clinical trials also allow testing and monitoring of the effect of a treatment on a large number of people to ensure that any improvement as a result of the treatment occurs for many people and not just a random effect for one person. Because there's always stories around of somebody getting a new treatment and it working, but when it's tested in many more patients, it it doesn't. And it might sometimes, it is just luck. And most modern medical treatments are a direct result of clinical research. And these statements come from the NHMRC. So this is probably one of the favourite slides of any paediatric oncologist, because it gives us the best example of how improvements have been made in paediatric acute lymphoblastic leukemia. And so you can see that the different dates along the slide there of outcomes for ALL from back in the 1960s all the way up to 2009. And as you can see, there's been a steady improvement in outcome. I'm looking at survival here over this period of time, and it's all been due to clinical trials. And you can see in the bracket that N equals 402 at the bottom up to N equals 7,835. That's a number of people in these clinical trials that have been treated and led to these improvement in outcomes. So there are various types of clinical trials. There are things like prevention trials, and that might be, for example, of using aspirin to try and prevent heart attacks in adults. There are diagnostic and screening trials. So some of them include, say, PSA testing in prostate cancer or mammograms in adults for breast cancer. But in particular, it's actually been done in neuroblastoma, predominantly in Japan, initially at 6 months of age and 18 months of age. And there they did a screening trial to try and detect neuroblastoma early, before it potentially metastasized and caused poor outcomes. And very interestingly, both at the initial 6-month trial, which was completed now probably 20 years ago, and then when they were 18 months of age, both did not show actually any benefit of doing screening. So it's very interesting. At 6 months of age, everyone realised it to be too young, but because many children are diagnosed with high-risk neuroblastoma around the 18-month to 3-year mark, the thought was maybe at 18 months it would protect some, but unfortunately it did not. So I'm mainly going to talk now about treatment trials, because this is what we're really interested in managing neuroblastoma. So just starting with the order of, I suppose, development of the trials, in that they all start with preclinical trials. And so these trials are not done in humans. And the goal is to measure non-human, so this might be a mouse, for example, efficacy, so how it works, toxicity and pharmacokinetics, or PK, in cell lines and often in mouse models. It can be performed by any sort of research. You don't have to be a clinician. And the aim is to give a signal or response that can be taken forward to human trials. It's nice to know that around the world, because there's so many different sort of organisations and groups do their own research, in the lab for neuroblastoma, and the reality is historically from that sort of basic lab research to getting to the use of treatment in all patients, it takes many years. And for most of you who've got a child with neuroblastoma, you don't want to wait 10-15 years for a potential new new drug that works to get into the system. You want to be quicker. So there's actually a big group that have got together from Europe and North America, looking at trying to do that and trying to find a way to get drugs from preclinical level all the way through early phase trials to standard of care trials if they're proven to be successful. And this is actually the abstract from this paper, basically reminding us that really there's only been one new class of targeted drugs that's been incorporated in frontline therapy for neuroblastoma since the 80s, and that's the anti-GG2 antibodies. Most of you will be familiar with that, as it's now standard of care in high-risk neuroblastoma. So this article is just to summarise really what this group is trying to do. So it's this new drug development strategy initiative, and they're getting together to look at preclinical data to start with of 40 sort of targets, and then prioritising them so they can go forward in the early phase trials. And I've just got to mention there a few of the drugs they're looking at targeting going forward. And that the real reason for this is trying to get them to be prioritised and getting them to be to the clinic much quicker than usual. So what are phase 1 treatment trials? So these are the first trials, often in human, so often known as first in human trials. And they are performed to test a new intervention, usually a drug, in a small number of participants to test safety. And that is their prime reason for doing the study, is to determine a safe dose and identify side effects. And as the primary reason for the trial is not efficacy or whether the treatment works, classically studies have been open to multiple tumour types. And in non-oncology trials, they're open to healthy participants. So to be eligible for these trials, usually you have to have refractory or recurrent disease. And historically, ideally, you've had, well, not ideally, but you're left with patients who have no known curative therapies or no therapy proven to prolong survival without an acceptable quality of life. Now, included in phase 1 trials now, phase 1b trials, and they include a sort of what we call a cohort expansion, where there's a particular group within the trial, they try and get a few more numbers in to see if they can get any more information. So I thought I'd just briefly talk about the risks and benefits of phase 1 clinical trial participation. This is now a fairly old paper back in 2014, but it's still relevant today when it comes to, why do we do phase 1 clinical trials, and how they potentially benefit both the physician but also the patients and the families. Because basically in the old days, when we were just trying a new drug, especially though it always get tried in adults first, there's maybe about a 5% chance that you'll get any sort of signal to say that this drug could be working. And that's because you might be getting a dose that's too low for it to work. It might be that the drug isn't going to work in your particular cancer. And so the benefits were relatively limited, for the individual on a phase 1 clinical trial. This is now changing because we've got, we're better at what we do. So modern phase 1 clinical trials basically are using more targeted therapies. And so we're often now limiting what cancer is being treated in these phase 1 trials, or what particular mutation that we're looking at. And so now, because we're targeting our trials much better, the potential positive outcome for the actual individual patient is increasing. So an example of a recently completed phase 1 clinical trial, this is through the COG, the Children's Oncology Group, of a new drug combined with irinotecan, which is a known drug. Now, this is one, for example, being used in lots of different types of tumours. As you can see, the conclusion from this is really just about, okay, what dose is the appropriate dose to take forward to potentially a phase 2 trial. So there's no conclusion about does the treatment work. It's all about what the dose is. Now, there are now phase 1 trials that are neuroblastoma specific. So, for example, there's been a recent study published combining zoledronic acid and cyclophosphamide. And that's through the NANT group, which some of you may have heard about. And below that is the first phase 1 clinical trial used by the Memorial Sloan Kettering group in the US, looking at their humanized antibody against neuroblastoma. So, and this is just an example, an old example actually, of a phase 1b trial. And this is the first trial looking at the, what we know now as a standard of care monoclonal antibody that was initially used with IL-2, or interleukin-2, in neuroblastoma. And so you can see this was published back in 1997. So it takes a long time to get to a standard of care practice. Might just move on now to phase 2 treatment trials. So these studies are done in a larger group of people, potentially up to several hundred, to determine efficacy. That is, whether it actually works as intended, and to further evaluate its safety. These trials are only performed after a phase 1 trial is completed, and usually measures event-free survival, or EFS, or progression-free survival as the primary objectives, and overall survival is often a secondary objective. So again, phase 2 trials can be performed in multiple tumour types. For example, here's another COG trial looking at a new drug in lots of different types of solid tumours, including neuroblastoma. But we're getting more and more phase 2 trials now that are specific for neuroblastoma. So this study, many of you may be aware of, also out of the US, not through the Children's Oncology Group, about DFMO. And so this was a trial, a single-arm trial, and that's very important to note here, that trialed this new drug, DFMO, in patients with neuroblastoma who are already in remission at the end of what we call standard of care therapy. And what they published was the outcomes following this study. So you can see here the 2-year event-free survival of 84%, and the 2-year overall survival of 97%. The problem with single-arm trials is what you compare it to, because we don't know how they would have been if they didn't get this treatment. Maybe their outcomes would have been exactly the same. So what they try to do is compare it just to the previous ANBL-032 study. So that was using the chimeric antibody, because most of the children who participated in this study had already had that same treatment. And so it got published outcomes for that. And so they worked out that probably the equivalent would be about 75%. So they were suggesting, obviously, that this means our treatment might actually be better than what the previous standard was, which was just at this point surveillance. Now, a lot of people, because it was a single-arm study, didn't recognise this as being true evidence of the benefit of DFMO. So the DFMO group tried then to try and match the patients as much as possible to other patients treated at the same institutions, but who did not get DFMO. And so they've got some longer data here. So you can see here the 2-year event-free survival and the 5-year event-free survival of DFMO. And they've matched that against those who had the same treatments up until DFMO treatment at the same hospitals. And they matched them for the NMIC amplification and other biological characteristics as well, to try and show that, hey, this really does show that DFMO is better. And you can see that here, that at least statistically, that is the case. But again, this is still just a single-arm study, and so there's always the possibility of bias that can be brought into this. So another example of a phase 2 trial that was a single arm. This is out of Memorial Sloan Kettering, and this is with their vaccine trial. And so this is the one they did also in relapsed neuroblastoma. And this is after, so they were eligible for this study after they'd already got back into remission with whatever therapy you wanted to give. And this was then followed on by their vaccine treatment. And this is the summary at the end from that group about the results, because the results showed that the outcomes were quite favourable, quite positive with this treatment. As you can see here about the optimism regarding the results of the trial, it has to be emphasised that a single-arm, single-institution study has a lot of potential for selection bias. Patients with different numbers of prior episodes of progressive disease and therapies were included, even though we did find that patients with only one episode of progressive disease had a better PFS. So given the limitation of single-arm studies, a randomised trial of the vaccine following a uniform upfront regimen should yield a more definitive verdict on its efficacy. So, I think this is a really, pertinent sort of example of how these trials, yes, they suggest their treatment might be of benefit, can't prove it. And that's where a randomised trial can give you those answers. So there are randomised phase 2 trials. And so a good example of that, and this is just in phase 2 as well, was through the Children's Oncology Group, where they compared irinotecan and temozolomide with either temsirolimus or dinutuximab with the antibody. And so when they did that, they clearly showed that the temsirolimus arm didn't really have a lot of favourable activity, where the dinutuximab arm did have favourable activity, and they can compare them together. And so that showed us that one arm was better than the other. So currently, what have we got open for a phase 2 trial in neuroblastoma? So at the moment, there is a phase 2 randomized study using the irinotecan temozolomide dinutuximab as the sort of base treatment, and 50% of patients will get DFMO and 50% will not. And so this way, they're trying to answer the question of, this is our standard of care treatment for relapse disease, whether DFMO makes a difference, whether you receive that or not. So that study is still ongoing, so we obviously don't have any answers from that. So moving on to phase 3 trials. So these are done to study how well an intervention works in a large group of trial participants, from several hundred to several thousand. And it compares the intervention to a standard, so it's a standard sort of treatment versus experimental or a non-interventional standard of care. And phase 3 studies are also used to monitor adverse effects and to collect information that will allow the intervention to be used safely. And the best phase 3 studies use a method called randomization. And by doing that, it means it really limits the amount of bias that can be put in either by the physician treating your child or for the people trying to examine the results of the study. Because once you're eligible for the study, then you get completely randomly allocated to either the standard of care or the new treatment, to then be able to work out whether this new treatment really does work better or does it have more side effects, and as it doesn't improve things. So a couple of examples of phase 3 trials that have been published recently. The first one is from the Children's Oncology Group, and this is the trial where they compared a single high-dose chemotherapy transplant versus a tandem or a double transplant. And their outcomes showed that the double transplant had a better event-free survival. Likewise, over in Europe, this is the Cypen group, they also compared high-dose chemotherapies. Their standard was busulfan and melphalan. They compared it through what had been the standard in the US, the carboplatin etoposide of melphalan. And in their study, they showed that busulfan and melphalan had better outcomes than the carbo etop and melphalan. And so that went forward for the Europeans as their standard of care. So another classic phase 3 trial was the first one that used the anti-GD2 antibody dinutuximab. And so this was a randomization now quite a number of years ago, where compared the previous standard of care, which was just retinoic acid alone in maintenance, versus the antibody combined with GM-CSF and IL-2. And again, it was a randomization that showed that the experimental treatment did better. And there's then been some long-term follow-up study of that as well to show longer-term data to show the benefit of the monoclonal antibody. So what have we got available at the moment in phase 3 trials for neuroblastoma? So at the moment, the COG have a phase 3 study looking at a couple of different things, in particular looking at MIBG therapy. Now, unfortunately, just through how they got this study organised, this study is not available in Australia because the MIBG therapy that they use over there is a bit different to what we use over here. But it's a study that's doing a randomization to really see if that therapy helps. In Europe, they've also got their new generation high-risk neuroblastoma study. And this is a randomized study looking at 3 different randomizations one with an induction, so comparing their standard induction versus a German induction, high-dose chemotherapy, so comparing their standard busulfan melphalan versus a tandem approach, because that was shown, tandem was shown to be better in the US, and doses of radiotherapy as well. So these are available right now for patients around the world. So just moving on to some other types of trials. So there are things called pilot trials. So pilot trials or studies are defined as those clinical trials used to acquire specific essential information about a drug before beginning the pivotal trial. So the big trial will be used to make specific claims about how well it works and the safety. So recently in Australia, we were able to, at least in a couple of centres, through the Children's Oncology Group, have a pilot study looking at incorporating dinutuximab into induction part of the chemotherapy. So we know we use it all in maintenance at the end. So this was everybody getting the dinutuximab in induction. And so there were small numbers to see, okay, is this feasible? Is it tolerable? Can we do this without too many side effects? And obviously to look to see if there's any sort of signal to say that it works better as well. And so following on from this, there is planned a phase 3 trial where they're doing a randomization of the dinutuximab in induction versus not. Also, there's the AMBL19P1 pilot study that's currently open at many sites in Australia at the moment. And this is looking at a new post-consolidation treatment regimen combining not just dinutuximab with GM-CSF, not just dinutuximab with GM-CSF and retinoic acid, but also using irinotecan temozolomide as well. And then again to see if that's tolerable, and then to see if it's worth taking forward in a randomized trial. So what about N-of-1 trials? So these are I don't know if many people know about these, but these are very new trials. In fact, we've got one open at the Royal Children's Hospital called Taylor. And basically it's a safety and oversight trial of individually tailored treatment. Where basically if you, as an individual, find some molecular aberrations in the tumour, we can then potentially put together a couple of different drugs to try and see if its combination for this particular tumour works. There's N-of-1 because everyone's different tumours have different aberrations in them, and so there'll be different drugs that be recommended even for different children with neuroblastoma. And the primary objective of this type of study is to evaluate the safety and feasibility of this study design as a mechanism for administering individualised therapies to patients with incurable cancers. And the secondary objective is to describe the clinical efficacy of individualised therapies in patients registered on the study. In fact, I've got one patient right now on this who's got neuroblastoma. So what about case reports and case series that you might see published in various journals? And I've just listed a couple of recent examples of that. So of a newest drug called cabozantinib for relapsed neuroblastoma. It's coming out of a single institution of 4 cases that have just been trialled, and they're interesting to know about, but they're not great in terms of evidence. And the other one is looking at exceptional response to lorlatinib in someone with relapsed neuroblastoma. So again, that just gives people a signal to suggest this drug is worth studying further. So just very quickly, I'll just talk about the levels of evidence that come out of clinical trials, and what we should be looking at, saying this is the best. And so the best results come from phase 3 trials, okay, because we're dealing with what we already know is a standard of care treatment. And in a phase 3 trial, if the new treatment is proven to be better, that becomes our new standard of care. The next level of evidence is your phase 2 trial, because that's looking to see does the drug appear to work. Obviously, a randomized trial is better than a single arm, but sometimes in very rare tumours, and neuroblastoma can fit into that category, it's hard to get randomized trials up and running. Phase 1 trials gives very limited evidence about how well a drug works. And then you've got the case series, then you've got a single case report, and then at the bottom you've got an expert opinion. And the reason it's an opinion because there isn't any published data about a particular treatment modality you might be getting an opinion about. And they're individualized. You can ask a different expert and you'll get a different opinion. So for a parent, what do you need to consider when you're thinking about a clinical trial? So, if you're offered a clinical trial, either hopefully by your treating doctor locally, well, where is this trial open? Is it your current institution? Is it another hospital in your state? Is it in Australia, or is it just overseas? What is the cost financially? Fortunately, in Australia, there is no cost for clinical trial involvement in Australia. And in fact, some trials will pay for your to move, interstate, for example, and pay for your accommodation. to be involved. But if it's an international trial, what is the cost? Travel is expensive. Accommodation can be expensive. What about scans and visit payments? These are all sort of things that you've got to look into. And each, especially for overseas trials, the rules on how much you have to pay and things are very different depending on who you're dealing with. So I think it's important to work that out before you go. And what is the cost to your family if you do go overseas? You've got other children. Do you take them with you? Does only one parent go? These are all really difficult questions that families have to consider. And there's no right answer for many of these. It's what works for you and for your family. Ideally, what we'd like is to have as many possible clinical trials and treatments available locally. And we are fortunate that with Ange Chog as our sort of group, we've got contacts throughout the world, and we are getting more and more clinical trials available in Australia. And it won't necessarily always be at your particular institution where we are within Australia, but we're getting more and more trials open in Australia. So the need to go overseas is becoming less, which is good. But there's always going to be other trials that are not going to be available locally. For example, the vaccine trial in Memorial Sloan Kettering, is not available in Australia. Although we're in contact with them, and at some point it may well be, but right now, unfortunately, it's not. So I've hopefully given you a bit of a rundown on clinical trials now, and very happy to hopefully you to ask some questions, so hopefully I can answer them.
Thanks so much, Marty. That was a really great presentation. It's just such a complex world of trials, and to have your guidance on it is really helpful. I'm sure you're giving parents a lot of really good advice. There has been some questions that have come in. The first question we had is that parents face difficult choices when considering overseas trials, especially those DFMO and vaccine first remission trials. Sorry, I just lost my question there. How does one with limited medical knowledge make an informed decision rather than a gamble or a gut feeling?
Look, it is very difficult, and you're right. These new trials of people already in remission are very different. Classically trials have been for patients who are needing treatment because they've got active disease, whether it's upfront or in relapse. You want to do something. So these trials are even harder for us to work out at the moment, because often the DFMO trial and the vaccine trial are for patients already in remission. And so a lot of these kids will survive anyway. So it's not a matter of having to try something, because there's a reasonable chance that if you've already got down this far, your chance of cure can be reasonably high. And for example, there was a report from the COG about their AIMBL-0532 trial, which is the standard induction, the tandem transplant, high-dose chemotherapy, radiation, and so on. And if you had a good response all the way through, for example, had a CR by the end of induction, had a complete surgery, received your tandem transplant, received all the therapy as planned, it was around an 88% chance that you'd be fine. And so it's a lot of then time, money, and effort to go overseas for a trial may not be needed. In fact, there's a good chance it won't be needed. The problem is that we can't tell you who's going to be in that 88% and who's going to be in that 12%, who may benefit from these treatments. And at this point, because they've been these single-arm trials, we cannot say for sure that they absolutely work. And sometimes it comes down to as well, the toxicity involved. And the DFMO study has shown that the drug at least is very well tolerated. And so for a lot of people is, well, what have I got to lose? You know, you can still go to, you can still, when you're in town, go to school and things like that. You know, and admittedly, I think many of us would be saying, if that study was available in Australia, we'd be perfectly happy for people to utilise it, because it is well tolerated, and as you can say, there's not a lot to lose by doing it. So it's a really tricky, you know, question for parents to know about, you know, whether we should be, you know, going overseas, and there is no right answer, and that's where we find as clinicians difficult, and I'm sure it's no better for families, because it's really hard to give guidance on the benefit, because we just don't know. For an individual in particular, is it going to be a benefit?
Yeah.
So I don't know if that really answered your question, but that's probably because there isn't a, you know, an absolute answer that is right for everybody.
Yes, I'm sure that's how parents feel as well. They can pick that up, and it's so difficult for parents without, you know, without the knowledge that oncologists have to sort of take in all this information and make a decision that's right for their child. I'll just go to the next question, and it's come in. Trials are so important for the future of neuroblastoma, but trials are rarely encouraged by oncologists. Why is that?
Well, I'd like to disagree with you there, hopefully, in that in paediatrics, and you know, at least wherever I've worked, clinical trials have always been, you know, frontline for us, and we always aim to have a clinical trial open for whatever, you know, condition it might be. Certainly in adults, it's less. There's a lot of private work being done, and so people might be treated with various different cancers in private land, and, you know, don't get exposed to clinical trials. But in paediatric oncology, everyone goes through the big, you know, hospitals, and we all have clinical trials available. Unfortunately, you know, in neuroblastoma, the current big high-risk study that's available in the US is not available in Australia. So it just means we don't have that trial available. There is a big European trial through SciPen, so that is going to be opening in Australia as well. But it's a very different platform to what many sites in Australia are used to. And so each sort of hospital sort of has to sort of work out, you know, are they happy to change, you know, platforms? You know, they've been treated with the North American Children's Oncology Group for many years, possibly, then change to the European way is very different for them as well. But when there is a clinical trial that's available, most pediatric oncologists will be wanting to have it open and encourage patients to be part of it.
Okay, yeah, thanks for that. Question 3, it's sort of, I think it's a more specific question that's come in. It's, if money wasn't an issue, would you advise an MYCN amplified patient to do DFMO or vaccine?
What I would love is actually a clinical trial comparing the two of them, to be honest with you, because that is going to be the only way of, you know, working out. In fact, the perfect clinical trial, even though it sounds funny, is to have a 3-way almost randomization of you know, placebo type of thing. Now, placebo-controlled trials are great, but in cancer, it's very difficult. You know, trying to give someone then a tablet for potentially 2 years of nothing. And we measure very objective outcomes that can't be sort of, it's not faked, but they're sort of real. You know, you either relapse or you don't type of thing. So having placebo is less important. But ideally, you would have, you know, 3-way randomization of surveillance versus DFMO versus the vaccine in NMIC amplified as well as non-NMIC amplified. Now, DFMO was originally designed for sort of NMIC amplification, but it's shown just as good, well, activity in non-NMIC amplified tumours as well. So, you know, that is the problem. We just don't have that sort of data to compare. And as I, you know, showed with the Memorial Sloan Kettering paper, and this is in the relapse setting, is that they themselves say, look, it looks promising, but I can't tell you how good it really is because we don't have that direct comparator. And so if you ask them directly, of course they'll be saying, yep, come to us, use our clinical trial, we've got good experience. And that's fine, but that's what they do. They've got the bias of knowing their own treatment and wanting people to use their treatment. And if you ask the DFMO people, they'll say the same thing. So we're in a way unbiased here in Australia to some extent because we don't have easy access to either. But we have the correct answer of saying, look, we don't know. And people want to have answers. And I understand that people want to know what is the best treatment. But the reality is we actually don't know because the trial hasn't been done yet. And that's the problem, is that they're out there and they're potentially available and people are saying, yes, I do this and I've done this and I've had it, I'm now cured type of thing. It's really hard to ignore that information and do nothing. And I think a lot of families struggle with their oncologist not being able to give that advice of this is what you should do. And the reality is that it's because we can't, as much as it's hard to sort of accept, because there's always people willing out there to tell you, yes, our treatment works, it is good.
Yes. Yes, I think, definitely. No, I've been in that situation where you're talking to your oncologist and you just want a definitive answer and, they can't give you one. And so then you turn to alternative sources, and that might be other parents or it might be other chat groups, and, you hear different things and you wonder what's influencing you more. So, yeah, thanks for that answer. I've got another question. Is there a way of getting clear evidence without randomized trials, as parents naturally don't want to do randomized trials in case their child doesn't get the trial drug or treatment?
Well, the short answer is no. There have been plenty of trials that in various different cancers where the new treatment or experimental treatment just doesn't work. And so you get potentially more toxicity without the benefit. So an example of that is in osteosarcoma, so a completely different tumor. There was our standard sort of chemotherapy that we gave. There were 3 different chemotherapy drugs, and there was another 2 drugs that work quite well in relapse. We know that you can see good responders in relapse. So I thought, let's bring it in to the upfront treatment strategy. And so it was a randomization for people to so half of them got it and half of them didn't. And when I looked at the outcomes at the end, absolutely no difference in the treatment. So it didn't actually create any more cures at all, but their chemotherapy was longer and they had more episodes of febrile neutropenia and got sick. So it's not a guarantee that the new treatment is going to be better. It may theoretically, make you less well off. So, and the whole reason of doing the trial is because we don't know. And the randomization is to prevent bias as well. Because, even as oncologists, sometimes we think, I think this person will probably do better with the new drug. If you keep only putting in the ones that you think are going to do better, you're going to show that they do better in a way. And, the ones who think you're always going to do badly because they've got worse disease, for example, when you put them into the other group, then they won't do as well. And so you're biasing the results. And so it's hard, but you have to go into these trials not knowing whether the experimental treatment is going to be better and acknowledging that often they aren't. And, we've been somewhat fortunate in neuroblastoma that, we've done studies that have shown benefit. So in terms of the antibody when it first used showed benefit, double transplants seem to show some benefit. Been plenty of other studies, in particular something like Randomized sarcoma through Children's Oncology Group. They've gone through their last 30 years of trials where they've done randomizations, and every time there was no difference. So the new treatment didn't make any difference at all. So you can't go into it expecting or assuming that the new treatment is going to be better.
I've just got a question myself before we jump into another one from the group. I mean, why is it that that just generally trials take so long?
So the big trials, the big sort of phase 3 trials, it's because of numbers and overall the rarity of pediatric cancers. So, we're doing very much international studies now to get those numbers, because in Australia, we don't have enough patients to do, say, our own trial on neuroblastoma, checking 2 different treatments. It would take 30 years to get enough to prove. So it comes down to statistics, where basically if we want to actually really prove one thing is better than the other, we're going to need a certain number of patients to be able to do that. And so it might be several hundred patients to be able to prove that benefit. And it's complex in terms of the stats. So if you're trying to prove or make a difference between, say, 10% to 80%, in a way, you actually won't need that many patients to show that, because it's such a big difference that it's kind of easy to see if you're really going to get that. Now, you're never going to find a treatment that's going to improve outcomes from 10% to 80%. We're looking at, neuroblastoma now, for example, maybe improving things from 60% to, say, 70%. So when you're doing only a small amount, you need big numbers to prove that's not just by accident. Because some patients are going to do better than others. We know that. It might just be by luck that some of them are all in one group. So you need big numbers to really prove that it's not just chance. And you need big numbers often to show that. And so that then takes time. And of course, when it comes to relapses, they might not occur for 2, 3, 4 years off treatment. So not only do you have to follow them, in high-risk neuroblastoma, it's down to like 18 months worth of treatment pretty much. And then you've got to wait another few years. And it might take 4 or 5 years to get enough patients in there. So then the whole thing's going to take 8 years or so. And that's unfortunately the only way of getting the evidence to say that one thing is truly better. In the relapse scenario, it might be a bit quicker, because the input is just whether you don't relapse again, and often will occur quicker in relapse neuroblastoma because treatments haven't been as good as what we like.
Thank you. I'll go to what seems to be, I think, the final question. I'll just read it out. When will our children have greater access to genomic testing to help drive and inform more N1 trials here in Australia? Zero Prism is holding off to 23, 24, though too many, I think it's Kayas, I think CAYA, is that children, will relapse and be unnecessarily harmed and die before then. So I guess the question is about when will the children have greater access to genomic testing and the help in drive and inform new trials here in Australia, given that PRISM is holding off until 23, 24.
So the 2 parts, so the current PRISM framework looks at the moment, high risk tumours only, and a sort of rare cohort. So in this particular instance, then usually be relapsed neuroblastoma. So you only find out about it sort of after you've already relapsed. Then you're eligible for PRISM. You go through the usual process of then trying to look for aberrations that might be targeted. Now, there's a big difference though between having information of potential targetable aberrations and having drugs that actually work. We've got ones that work in theory and work in labs, but do they work in a child with neuroblastoma is a very different question. Can you combine drugs as well? So that's where, such a study like we've got here in Melbourne, the Taylor study is about trying to do this N-of-1 study. And I'm sure there's other places that are looking at that around Australia as well, to really do individualized therapies. You're relying on getting the drugs from drug companies. We don't like, obviously, families having to pay for these treatments, so we try and get it from the drug companies compassionately. They won't always give the drugs to us, so it's hard. We've got to have some data about the safety of the drugs. in children before we can give them out as well. So we don't always get answers that we can utilise from PRISM. PRISM is going forward to doing genetic testing on all tumours upfront. So that's going to be particularly important, say, in the neuroblastoma community looking for ALK mutations, because that's not something that we've classically done upfront for most. So now there's looking for an ALK mutation, so then you can potentially consider adding in an ALK inhibitor during your therapy, and that's actually the Children's Oncology Group and the CyPen group are both incorporating lorlatinib into upfront treatment for those with ALK mutations. So we don't have those, obviously we don't have the COG trial open here, but that's something that can be considered by the treating doctor at the time. But we don't usually involve genomic analysis up front because we've got our standard treatments and we don't know the benefit of adding in extra things because it hasn't been tried before, and then it might just include toxicity. So
or it might, sorry to butt in, it might also though help take things out. If from the frontline treatment, if it was that a child didn't need, a stem cell transplant isn't going to help, or is that the sort of information that you can also get from PRISM potentially? No. I think the short answer is not no. If someone's got a high risk neuroblastoma, that's still defined by age and whether you've got endemic amplification, which we all can do easily locally, and the extent of disease. We don't yet know whether there are some subgroups within that could deal without transplant, for example. So there's still so much for us to learn and try and get from older clinical trials and current clinical trials. But we're in the high risk group, we're really still concentrating on trying to improve outcomes rather than decrease the amount of therapy at this point, because we're still not satisfied with our cure rates. Yeah. Well, I think that kind of come to a natural conclusion now. There's no more questions that have come in, but my thanks, Marty, for a great presentation and giving your time today to help educate families here in Australia that are considering trials or trying to get their head around what are the trial options out there. That was very helpful. And and our thanks for everything you're doing for neuroblastoma families. Very appreciated. And
no problem.
Thanks for today.
No problem. Thanks, Stephanie. Thanks, Lucy, for asking me along.
Yeah.
Have a good rest of your meeting.
Yes. So just for everyone that might be listening, we're going to now have a lunch break. And then people can join back in at 2:00. And at 2:00, our session is on relapse strategies and the current options in Australia with Dr. Bhavna Padney from Westmead. So if everyone wants to have some lunch, enjoy their lunch and tune back in at 2:00. All right. Thank you very much, Marty. And we can all click off now. Bye. Thank you.